Welcome to the Prairie Health Pulse podcast, a program dedicated to taking you behind the scenes of healthcare, sharing firsthand knowledge from healthcare professionals, and putting you in the driver's seat on your journey to lifelong health and wellness. Listen and learn about how healthcare delivery is changing on our weekly podcast.
Thanks for tuning into the Prairie Health Pulse. In today's episode, we're diving into a lot of the challenges that are facing rural healthcare. In the last couple of years, there's been an increased trend in the number of closures or mergers and partnerships amongst small rural hospitals. And being a small rural hospital, we wanted to cover some of the reasons why. Prairie Memorial Hospital has actually been around for almost 100 years. Next year is our 100th anniversary. So it's been through a lot of the changes that have taken place in healthcare. And today's episode goes through a lot of the changes that have taken place over the last several decades that have made it a lot more challenging. The episode today is taken from a presentation that our president and CEO, Annette Schnabel, gave to a local group. The presentation was serving as a foundation for future possibilities for our hospital. For anyone listening who's not aware, Prairie Memorial Hospital is in partnership discussions with a larger organization, OSF. This is a process that's going to take at least 6 months or more to determine whether that's even a viable option. But our presentation here is going through why it's important to consider those options and what's compelling that forward thinking. The original presentation that was given was close to an hour, but we're trying to keep to our 15-minute time slot and keep our time down so this is easily listened to. And with there being a lot of great discussion to include, we just wanted to make sure that the topics covered really hit home the challenges facing rural healthcare. So now let's jump into the presentation.
Our healthcare system is pretty much becoming unaffordable. We are about almost approaching 20% of the gross domestic product, and it continues to go up, and we need to figure out how to do things differently. So there's a lot of things happening in terms of our ability to pay for healthcare, so we have to do something different. In the past, we didn't have insurance that we dealt with. We didn't have Medicare. We didn't have Medicaid. We didn't have all those programs. People had to be able to pay for their services. Sometimes I think that might not have always been in cash. It might have been in chickens. People stayed in the hospital when they did receive hospital care long periods of time, and that happened really until the 1980s when there was changes in the payment system for health care. Today, our average length of stay in the hospital is 2.98 days. Like I said, it used to be weeks, and it's only 2.98 days now. As all healthcare is trending, we move more and more towards outpatient services. Currently, 86% of the care that we do is in outpatient areas. We recognize that with the Affordable Care Act, that kind of changed the mix a little bit in terms of the percent of patients that were Medicaid or Medicare and what that did for the employers. But we recognize that our employers can't afford necessarily to keep funding the level of health insurance for their employees that they have in the past as well. And there's also been a movement in healthcare called the consumer. Well, we all are consumers. We've been all of our lives, but the way the healthcare system has been set up with our insurance, you don't tend to use it the same way as you do when you go to the grocery store and you're making choices. So there became more of a consumer movement towards how do I get what I want when I want it. Because of that, all this thoughts with this cost of care, were we getting quality outcomes? So several of including the federal government, started looking at, we want to pay you for getting outcomes rather than for just doing care. You can constantly do care, but are you getting good outcomes? So they started working towards moving things into what they call value-based care. Technology is something that's significantly changed over time. We don't use frogs for pregnancy tests anymore. We do lots of chemicals in our laboratory. There's been a lot of other things going on in what we call disruption to our way of delivering care in the sense of your smartphone, how do you do things differently, how do you use your watch to help you monitor your health. There's just a lot of things happening. So we recognize that healthcare is truly changing in the delivery system. In the old way, you had patients that went to doctors and doctors told them to go to hospitals. In today's world, it's so much different that we have hospitals, doctors all working together. We have patients, we have employers making decisions. We have insurance companies that are driving people where to go. So things are just different than what they might have been in the past. For a rural hospital, we are thinking about what's happening in a rural setting, and there's lots of challenges for us in a rural setting that maybe are not necessarily challenges in an urban, although some of them probably are. In 1983, there was a program implemented from the Medicare system that was a new way of paying for us. It was the DRG system. The DRG stands for Diagnosis-Related Grouping. So basically, Medicare said, if you have this type of a condition, we're going to pay you X amount of dollars, and you have to figure out how to care for that patient with those dollars. And there was a little bit of exceptions to that, some variations, but basically, if you were going in for a total knee replacement, they were going to get X amount of dollars, and you have to figure out how to take care of that patient. From that, there's a lot of hospitals that couldn't afford to care for their patients based on the dollars they were being paid under the DRG system, and we started seeing hospital closures happening. At that time, we saw about 140 rural hospitals close across our nation because rural hospitals couldn't have the volume, et cetera, to manage the cost of the care within the DRG system. So in order to save rural health care, the federal government created a program that was implemented in 2004, the Critical Access Hospital Program, which, as I've said before, we are designated as a critical access hospital. By doing that, they put us on a cost reimbursement program rather than under that DRG system. So we have to evaluate our cost annually. We submit that to Medicare, and then Medicare determines what they're going to pay us for the next year based on our previous cost, and that is supposed to be at 101% of our cost in order to be able to keep us profitable enough in order to stay open and care for our rural communities. They also created what's called rural health clinics and federally qualified healthcare centers. Basically, those are physician offices that also get that special reimbursement. But then came along the Balanced Budget Act of 1997, which implemented what's called a prospective payment system, and that affected mostly nursing home type facilities, a little bit of home health, in which they were then also put on that same kind of like the DRG program, a little bit different, but it basically said we're going to limit the amount of money that we're paying you. We're not going to just have open book. And so that led to some more challenges from our rural areas. And then in 2011, there was a Budget Control Act that implemented what's called sequestration. It actually took effect in 2013. Basically, in sequestration, as long as there is a federal deficit, they're going to cut payments to providers by 2%. If the federal deficit gets high enough, they'll actually cut by 4%. Because we have a federal deficit, instead of getting that 101% of our costs, we currently get 99% of our costs. So that means now, we have already told you that we lose money on Medicaid. That means that we actually now also lose money on Medicare. Not near as much, but we do actually lose money on that. So when we look at our payer mix that I told you is 43% Medicare, about 14-15% Medicaid, you can see the biggest part of the care we provide is to people under these federal programs for which we are guaranteed to lose money. So that is problems for us. Then the Affordable Care Act of 2010 came along and started being implemented. And one of the things that came along with that was when we looked at the people who were uninsured, many more of them became qualified for Medicaid. So when they're uninsured, we often don't get anything for them. When they're under Medicaid, we get some funds. So we were supportive of the idea of people moving into the Medicaid system from being uninsured completely. However, following the Affordable Care Act, we continue to see additional hospital closures across the country. Through 2017, another 64. Now that number has been growing. They have announced some more these last month or so, some more hospital closures. More than half of the hospitals that have closed have converted to another type of healthcare provider. So again, why do rural hospitals have more challenges than those urban hospitals, as I tend to believe, is one, we have an aging population, which means we have more people on Medicare than people in our counterparts in urban areas. More people on Medicaid because we have a higher poverty level. We have greater difficulty recruiting providers and care staff into the rural areas from the perspective of, one, did they come from a rural area? Do we do a good job of developing these providers, these staff from our communities? Often they go off to school and they decide they want to stay off in these larger areas. So it's a challenge for us to recruit providers and staff. Across the nation, the number of providers available per patient is declining. So that's one of the things you've seen a shift in how we care for patients here in the sense of number of physicians versus nurse practitioners. So we need to think differently in the sense of what does this person's training allow them to do and allow them to do that? And then what's the next person's training allow them to do and have them do that? So we don't want our physicians doing things that a nurse practitioner can do if that's not necessary. But that's just from a provider perspective, but we also have challenges with nursing. And actually, nursing goes through cycles of shortages across the country, and we're back into a shortage of nursing. We're also, again, experiencing shortage of lab techs and therapists. So there's a challenge, again, for us from even a staffing perspective of all types of staff. Another thing that's a challenge for us in rural healthcare is specialization of medicine. Everybody's knowing more and more, and so you have a specialist that specializes, and so people want to go to the specialist. And in rural areas, we don't have sufficient population to have that level of specialists within our community. So we need to think about how do we work with those organizations that do have that specialist, and how do we make sure that people understand what our primary care can do and stay within our primary care community. So that's an area of challenge for us. And then in our rural areas, we also have, from I'll call sicker issues as well. So we have the opioid crisis. We have a greater drug population, drug challenge in rural areas than what our suburban parts do. I'm not going to say that the inner city maybe doesn't have that same. We also have higher mental health needs. We have higher suicide rates in rural areas. And then we have transportation issues on top of that. How far away is something? Do we have a way to get to that service and to get to that care? So those are things that tend to be more of an issue for us in rural areas than in urban areas. So some of the things that have been happening in healthcare to address this is making the provider actually more accountable to the outcomes of patients. So there's things that have been implemented called accountable care organizations. So providers become part of these organizations, and they have to figure out how to do better quality care, get better outcome for their patients, have better access for their patients, and decrease the cost of the care to the payer of that care. So Prairie is in an organization that's an ACO that we serve both Medicare and Blue Cross. Those were the first two we got involved in. We know more and more insurance companies are doing that as well. We have to do a lot of quality reporting. So as far as an accountability perspective, we are reporting on lots of different measures to say that we get the right kind of outcomes. We're compared to others across the nation to say that we're at the levels we should be or are we not at that level. I mentioned the investment in technology. So we also have to show measures on how we're using that technology. They have standards of how we should have certain things in our medical record, what's searchable in our medical record, how do we have that information, what's entered by the physician versus the nurse. We actually have rules and regulations on that. And there's actually funding to us that can be taken away based on our performance or given to us if we perform well. And that's one of the latest programs for that is called MACRA and MIPS. Seems like every couple years we get some new acronyms to share with you because they'll update the program and then we get new acronyms with them. As I mentioned about the hospital closures, we also are seeing hospitals merge with other organizations. It could be large organizations merging, it could be small organizations merging, different sizes. There's 13 in the state of Illinois that have merged since 2005. So one of the reasons why rural hospitals merge is actually to be able to provide a better quality outcome to their communities. So as we look at value-based purchasing, which means being paid for your outcomes and being all to have that quality outcomes, rural hospitals don't typically have the capital to be able to spend to create all the things that go into being able to do that. So being a partner with the larger organizations and being to be able to share that cost across many hospitals, many different sites of care, actually makes it more affordable to do these things that we're required to do. The other thing that rural hospitals do is we merge in order to gain market share. Sometimes the recognition of being associated with a larger organization, a more quality organization, improves your market share. It also enables you to work with that larger organization to maybe keep more patients in your community through different programs. So that's one way, and it also can create efficiencies. When we have lots of different things that we have to do from a regulatory perspective, I can't quote to you the hours, but there's been studies recently that have identified the number of hours we spend in a year just dealing with regulatory, and it's crazy numbers. But we still have to meet all the same quality criteria, pretty much, as the bigger hospitals. Those exceptions typically come because we don't do a service. We have to figure out how to meet all those same things. And so the cost of doing that when you're merged with a larger organization actually becomes more efficient because, again, you can share those costs across that organization. The other reason why hospitals tend to merge is because of long-term unprofitability and financial stress. Depends on the community profile. So how much of your Medicare and your Medicaid do you have in your community, or do you have some good payers and private insurances? We tend to have, as a rural hospital, because we're small, less negotiating power with insurance companies. So what a larger organization might be able to get from a per day or care work might be more than what we might be able to negotiate, or even if we can even get in with that insurance company, because they're going to be looking for a number of lives that they want to be able to cover, to spread that. So they may be able to, the insurance company or a large employer may be able to say, I only want to work with this organization. I'm not going to work with this smaller organization. So we can't even care for those patients. We can't even get in those contracts because we're a small organization. Originally, the initial reason people merged or whatever was all because of that financial stress. Today, it's really more, that might be some part of it, but it's also about the strategic thought about where's our future, what's different about healthcare now than it was in the past. So thinking about the reasons we merged today might be a little more strategic rather than just we can't survive. When we look at that, I keep talking about sharing the costs across an organization. Some information that we looked at was the important amount of lives that are necessary to be able to cover, and to be able to really develop the scale that's going to be necessary in the future. One of the recommendations that came from the consultant was you need at least 250,000 lives. Well, we don't have 250,000 lives in Bureau County. So I need at least to be an organization of about a $2 billion to $6 billion net revenue. We are not anywhere near that size. So based on their kind of thoughts, we are too small, so we want to be part of an organization that's larger. It's likely that in order to be able to be successful in the future, we need to be able to be successful in that value-based environment. So can we get the outcomes? Can we get that that we need to have? And we need to be able to align with our physicians and our providers. And again, the ability to do that is easier in a larger organization.
It doesn't stop here. Access other podcast episodes and resources related to today's episode by visiting www.prairiememorial.org/podcast.